You are live.
All right. Good morning, everyone. It is a pleasure to see you all virtually again. The last time we were convening, we were unfortunately starting to see the beginning of what was presumably a third wave. And unfortunately, I think that wave is very much before us. This has been an incredibly challenging few weeks for everyone, but most particularly our healthcare system and the incredible essential workers who have been fighting throughout this entire crisis to maintain. And right now we are facing a dual reality. It is the very sad truth that yesterday we passed a pretty grim milestone, which 5,000 Marylanders who have lost their lives due to the COVID-19 virus. It's easy in these moments to get caught up in the numbers and the statistics and the trends, but the reality is, of the 5,000 Marylanders who lost their lives to this horrible disease, they were mothers, they were fathers, they were uncles, they were aunts, they were sons and daughters. And the very, very real toll that our state is facing is incredibly, incredibly challenging. And it is something that I think all of us have to be even more mindful of, that even though we do have this incredibly positive light at the end of the tunnel, which on the same day that we passed 5,000 deaths in Maryland, we also began administering the vaccine for the very first time, something that truly will be something that we look back on 10 years from now and I think can be incredibly proud of the ingenuity of the human mind in solving a problem. Early on, a number of us were having conversations of this taking 4 to 5 to up to 10 years for a vaccine. And here we are 10 months in, and we have potentially four potential vaccines that are almost ready to be distributed. One that is being administered right this very second, which is absolutely incredible. And so the good news is that there is an end in sight. The bad news is that we're not through this. And so I'm very pleased today that we will have our experts from across the state, from the hospital system and from the Department of Health. I want to thank the acting secretary who is joining us today to talk both the dual reality here, the surge that we're seeing in hospitalizations and the challenge on hospitals, but also the important reality and promise of vaccines and their distribution across the state. So both of these aspects are very complex and challenging, and we're trying to do them both at the same time. So I look forward to today's presentation and hand it over to you, Madam Speaker.
Mm-hmm. Good morning. I want to thank everyone for joining us this morning. On Monday, we were all excited to see some of our frontline healthcare workers receiving the vaccine. But 61 Marylanders died from COVID yesterday. Our positivity rate is 7.5%, and 1,800 Marylanders are currently hospitalized. We will not be out of the woods for some months to come. Today, we have asked the Department of Health to provide us with an update on vaccine distribution and surge management, excuse me. We are joined by Acting Secretary Dennis Schrader, Dr. Ted Delbridge of the Maryland Institute for Emergency Medical Service Systems, and Acting Director of Public Health Services, Dr. Jaylene Chan. Thank you all for joining us today. You may proceed. Needs to be unmuted.
Mr. President, Madam Speaker, can you hear me?
We're good.
Mr. President, can you hear me, Mr. President?
Yes, we can. Yes, we can.
Okay, thank you, sir. Thank you. So, Mr. President, Madam Speaker, I'm going to just say a few words that reinforce your comments. If we can go to the first slide. And the fact of the matter is, although we have this great news about the vaccine, we still have a long road to travel with prevention, and we're going to double down on getting folks to wear masks, to do wash their hands and physically distance, and we're also pushing folks to get their flu shot. So this is really going to be really critical over the next several months while we're beginning to see the first implementation of the vaccine. If I could have the next slide. Just a couple of highlights on where we are with testing. We're now over 5 million tests, around 35,000 a day, and we're continuing to drive contact tracing efforts of over 100,000 cases and 130,000 contacts, and we've got over 1.3 million Marylanders that have signed up for the exposure notification. The key there is we've got about 5,500 people who have actually gone in and notified the system that they have been tested positive, and then that anonymously goes out to the network and tells people that they were near somebody who had been exposed. So this becomes is a continued effort, again, which requires over 1,500 contact tracers. Next slide, please. We've distributed over 86 million pieces of personal protective equipment, and we have upwards of 60 days supply for the major PPE elements like gowns and gloves. And then we're going to talk today, I'm going to turn it over to Dr. Delbridge here in a second to talk about the surge capacity. We had built a lot of surge capacity in the spring. We kept that in place, and we are doing more now. Of course, we're doing it in a way that allows us to keep people in the hospital with non-COVID so they get their care while we're managing the surge, because what we were able to do in the spring is shut down the hospital capacity for electives, empty them out, and that really wasn't helpful for the general health of the population. We want folks to seek care when they need it. So this is a much more precise approach, and Dr. Delbridge is going to tell us about it. So at this point, I have Dr. Delbridge, who has been a major element of, for those who know MIMS, they are wired into all the hospitals in a very key way. They have very robust data capability and connections throughout the state, and I'm very grateful to Dr. Delbridge for his efforts. He'll tell you here in a second, and then Dr. Chan will give us a detail briefing on the vaccine. So I'll stop there. If we go to the next slide, I'll turn it over to Dr. Ted Delbridge.
Thanks, Dennis, and thank you all for the privilege of speaking with you this morning. I'll try to provide an overview of a little bit of recent history, how we got to where we are, what we're doing, and maybe a little bit of what we think is going to happen next. Next slide, please. So right now, we know that Maryland's hospitals are balancing the burden or the responsibility of taking care of COVID-19 patients with a lot of non-COVID-19 hospital admissions and procedures. And our focus over the past time, especially in the past several weeks, has been to work collaboratively with the hospitals to monitor and manage the hospital capacity all across the state. We've done that several different ways. One, with some advanced planning, which created additional capacity. And that additional capacity was created both within hospitals, adjacent to hospitals, for example, temporary structures that annex space for emergency department operations, or increased space for intensive care patients within hospitals, alternative care sites, which I'll talk more about in a second, and most recently to facilitate patient movement when that seemed advisable. Since the beginning of November, or the middle of November, Governor Hogan has announced a series of measured actions that we're hopeful to prepare for the fall and winter surge of hospitalizations, and we think that that is having the effect that it was intended to. Next slide, please. So to back up just a little bit, toward the middle of November, there were approximately 7,000 people in hospitals across the state with a COVID-19 census of approximately 761. We saw the wave coming to Maryland. So we had Governor Hogan announce some requirements for hospitals to begin to implement their surge plans, especially when 85% of the state's staff bed capacity was being utilized. So we count beds every day 4 ways. And we've used since spring something called the Maryland Emergency Medical Resource and Alerting Database. It's a system where we are able to query hospitals, and typically it was designed to figure out what emergency department capacity was in cases of a disaster or a mass casualty incident. We've been using this on a daily basis for hospitals to provide us really detailed insight as to what's going on within their walls. And we count the beds that are occupied by non-COVID-19 patients, the beds that are occupied by COVID-19 patients, how many beds are staffed total, and how many physical beds there are. And there is a delta between how many physical beds a hospital has and how many they're able to staff on any given day. And part of that is by intent, and the hospitals intend to manage their own operations relative to the patient population they have within them. So we keep track of all that. And what we're really acutely concerned with or pay attention to is what is the gap between the number of patients in beds in hospitals and how many beds are staffed. So in the staff bed connotes a hospital's ability to put another patient in the bed in the next 5 or 10 minutes, for example, as opposed to a physical bed, which might be unstaffed, which would require some planning on the part of the hospital to amp up, if you will. So we wanted all the hospitals at that time to begin to make preparations to increase their COVID-19 related operations by making sure they had enough beds online and enough staff to operate them. And we also emphasized some creativity or flexibility on the part of EMS to direct patients to where there was space available, even if that meant at some of the alternative care sites we'd created, especially if the alternative care site was on hospital property, for example, annexing parking lot space that we had put temporary structures in to help expand emergency department operations. Next slide. Within a week, the census in terms of COVID-19 patients had increased to over 1,000. There were now 7,179 total patients in the hospital. And we emphasized to hospitals that it was time to begin to scale back elective procedure admissions, especially those where there was a lesser degree of time sensitivity, and most especially if they were likely to require some postoperative care that included mechanical ventilation, the need for an ICU admission or prolonged hospitalization. We were sensitive to as Dennis expressed, the desire not to have hospitals turn off in a way that would be an impediment to routine healthcare for folks. We didn't want to do that, but we wanted to make sure that things that weren't so time sensitive or urgent, the hospitals were planning to scale back and make space for COVID-19 patients as they arrived. Next slide. And then at the beginning of December, the hospital census now over 7,200 and the COVID-19 census above 1,500, we emphasized to hospitals that they really, in earnest, needed to begin to plan to bring unstaffed physical beds online, especially if the hospital statewide census reached 8,000. We haven't gotten at all close to that since then, which is a great thing. As I said, we monitor it daily, but we wanted hospitals to begin to make adjustments by adding or redeploying staff, creating more beds or animating the beds that they had, in earnest reducing elective procedures that required a bed or a ventilator postoperatively, and to begin really diligently trying to transfer patients to other appropriate treatment facilities, for example, the alternative care sites, which I'll talk more about in a second. Next slide, please. This sort of, well, doesn't sort of, it will give you an idea of how hospital census has fluctuated over the course of the past month. The top bar is the total census of the hospital. And as you can see, there's a cadence to this. It sort of reflects the ebbs and flows of businesses and hospital over the course of a week. And you can see along the bottom the census related to COVID-19 patients. The red line is the benchmark of 8,000. If that is hit, what we expect is the hospitals all to add 10% capacity. There are about 1,900 beds in Maryland hospitals that are unstaffed on a routine basis that they, in theory, could animate if the need arose. And that is what we were calling on them to do. And so we haven't gotten close to that. By the way, for frame of reference, an average day in a Maryland hospitals when there isn't COVID-19 in play is for there to be about 6,600 patients, and the hospital staffed to that accordingly. Next slide, please. So the sort of where we are today, care. Let me assure you that care is available for every Marylander who needs care. We understand, we have insight that the hospitals are exercising varying degrees of innovation and staff redeployment. As I visited hospitals, I realized that staff that is normally especially nursing staff that is normally in an administrative role is being called in or tagged to do clinical work that they are qualified to do. The statewide hospital census yesterday was 6,995. As of this morning, it's a little over 7,000, right about where it's been for the past several weeks. The COVID-19 census this morning is actually down a little bit. When the slide was made yesterday, it was 1,773. Today, it's 1,762. About 23% of COVID-19 patients are in an intensive care unit. Let me talk for a second about that. That is, if there's any good news in the current wave, that's it, or at least that's one piece of it. In the springtime, with that wave, intensive care patients made up closer to 40%. It hovered between 39 and 40% of COVID-19 patients who were requiring ICU care. We've learned a lot about caring for COVID-19 in the past several months. The resources are more robust to manage people, and we're trying hard to keep them out of the intensive care unit. That's a huge win, because intensive care unit beds are the most difficult to replicate within a hospital wall. And so then only 23% are requiring ICU care is a really big deal. But COVID-19 patients right now are making up about 25% of all Maryland hospitalizations. And it is a stressor on hospitals. Several of them over the course of the summer had done really amazing engineering works to do things like reverse airflow in the hospital to make rooms more appropriate for airborne isolation, which is an important consideration for managing COVID-19 patients. And so hospitals had done a lot of preparatory work, which is paying off right now. As I said, the hospital census is well below 8,000 and has potential to bring on an additional 1,900 physical beds if the need should arise. So lots of capacity in theory available in Maryland hospitals. Next slide, please. Some things that we're doing in no particular order. Earlier this year, in the course of the disease, we created for EMS clinicians, the EMTs and paramedics in the field, a viral pandemic triage protocol. The goal was to help EMS clinicians identify patients that are safe to stay at home. And so the EMS system gets a lot of calls for people who have been exposed and are worried they have COVID-19, or actually just visited a test site, just got the result, realized they have COVID-19 and they have a fever and they want somebody to check them out. And we wanted the ability to keep people out of the hospital when staying away from the hospital was the right thing to do. The EMS clinicians have implemented this thousands of times. When they encounter patients who are people under investigation or suspected of having COVID-19 in the community, the largest single disposition in Maryland is to keep the patient at home. We ask them to track those people and make sure that they stay well and that they don't deteriorate. And that has been our experience. So that is helping to decompress the healthcare system a great deal. 2 weeks ago, we launched the Critical Care Coordination Center. We do that at the MEMS offices in Baltimore, in our Emergency Medical Resource Center, which is responsible for routing all communication between EMS clinicians in the field and hospitals, trauma centers, and specialty care centers. Over the course of the 2 weeks, we have fielded now more than 100 calls from 31 different hospitals in the state and affected patient transfers to 26 different hospitals. What we heard in the springtime was that a community hospital might have intensive care unit patients who they were well equipped and able to care for in their hospital if only they had the space. And so patients who would otherwise be in the intensive care unit were sort of stuck in the emergency department, sometimes for a couple of days at a time. They didn't need the quaternary care that was available at the sophisticated academic medical centers. They really needed the care that was available right there if it was just available. And they weren't accustomed to transferring patients to other hospitals that were like them. I characterize them as lateral moves. There was never really, prior to COVID-19, a reason to do that. And so we stood up the Critical Care Coordination Center so that doctors and nurses who were taking care of patients in the hospital, and they were at a stress point, if you will, they were sort of maxed out, weren't being held to do administrative work at a time when we really wanted them to be doing the clinical work that they're qualified to do and patients are needing them to do. And so the Critical Care Coordination Center was made for that reason and has been wildly effective in helping to facilitate patient movements. And it's not uncharacteristic for us to, on one day, move a patient out of a medical center because of lack of space, and the next day for that same hospital to have space and for us to transfer a patient to them, and even when they're not typically accustomed to receiving patients like that. And we've had awesome cooperation and collaborative working with all the academic medical centers and the community hospitals in the state. It's been greatly effective. The HSET, or the Hospital Surge Engagement Team, monitors hospital capacity every day. And like I said, we pay attention to who's in the hospitals that have COVID-19 and who doesn't, how space is in terms of medical surgical beds and intensive care unit space. And we develop a watch list, hospitals to pay attention to that we can tell or have the potential to be maxed out on any given day. And we reach out to them and ask if they need any particular help. We want to make sure that they are aware of the alternative care sites and the space that's available in them. Those are the Laurel Regional Medical Center, what was at Washington Adventist Hospital in Tacoma Park, and the Baltimore Convention Center Field Hospital, which today collectively house about 146 patients. They have space to go, and the Convention Center has an abundant capacity to expand. And so we want to make sure that those paths are worn and people are quite familiar with how to get patients into those spaces so that when appropriate patients can be identified, we move them on. Next slide. And I think that's my spiel. I'll turn it over to Dr. Chan.
Great. Thank you. And good morning, Madam President, Thank you, Mr. President, Madam Speaker, and to members of the work group. I appreciate being here with you this morning to discuss our vaccination plan. So next slide, please. Thank you. So as we discussed yesterday and that we saw on Monday that some of the first vaccines occurred in the state of Maryland. This is Ms. Shawn Hendricks, who is a nursing director at the University of Maryland Medical System, who has been there for over 20 years and started there, I believe, as a nursing student. And she was among the first to receive a vaccine. And not only do we appreciate that, but we appreciate the work that she has been doing over the last many months, working with patients in a COVID unit, and just her dedication to the field of healthcare and nursing. She and others like her are the true heroes in this pandemic. So next slide, please. So wanted to provide a situational update to this work group. As you know, vaccinations have begun. And that we have placed orders out of our initial allocation from the federal government, and that we anticipate that every hospital will begin to receive their first doses of vaccines within the next 2 weeks. And so our nursing home vaccination program will also begin within this time frame. And some of the doses that we have been allocated in the state, we have authorized to be held back by the federal government to be deployed to the federal pharmacy partnership that I'll talk about in a little bit, so that they can have those doses to begin vaccinations in the nursing homes. Next slide, please. So the initial allocation and distribution is 155,000, and that includes 104,000 of the Madonna vaccine, as well as about 50,000 of the Pfizer vaccine. The majority of the Pfizer vaccines went to the nursing home program, and I'll talk a little bit more about that in a little bit. But after much discussion and also using the recommendations from CDC's Advisory Committee on Immunization Practices to prioritize frontline healthcare workers as well as residents in long-term care facilities, our initial distribution will be aligned with that recommendation from the federal government. You should know that they provide weekly updates to us on what we actually will be allocated. While we are projected to get as much as 300,000 doses by the end of this month, we do not always have a specific number that we can actually order off of until the end of each week or on a weekly basis. And so this is something that is a fluid situation, so we urge providers and patients as we work through this process. We are still in our very first week and working very closely with our federal partners. Next slide, please. So I wanted to talk through our phased approach. So in this 1A group, again, as recommended by the CDC Advisory Committee, our top priority will be healthcare workers as well as residents and staff of long-term care facilities and first responders. Once we have enough allocation to be able to provide vaccinations for this group, we will be able to shift our focus to be able to open up additional vaccines for individuals in 1B, who will include individuals at higher risk of severe COVID-19 disease. And then again, it's hard to define a specific time frame because a lot of it is predicated on how much vaccines might be available in the coming weeks and months. But our goal would then be to include people in phase 2 who are in critical essential infrastructure roles, including those working in transport, in education, and many of the other essential functions that we know are important for the function of our communities and our economy. And then once we have sufficient vaccine, then we're going to be able to open it up to the general population. Now, I will say that while we have currently 2 vaccines that one has been approved, Pfizer, and then Madonna Vaccine is on the way to being approved as soon as later this week, there are other vaccines that are in the pipeline that are in late stages of clinical trials, of phase 3 clinical trials. And so we anticipate, again, in the coming weeks and months, that those will also undergo close scrutiny and careful scrutiny by the FDA for potential approval, and that will also allow us to increase the amount of vaccine that is available to Marylanders. So let me shift to talk a little bit about the vaccines that are right now in front of us. So next slide, please. So the Pfizer vaccine, they shared on November 9th that their analysis of the phase 3 clinical trials had 95% efficacy in preventing symptomatic COVID-19 disease among vaccine recipients. So on November 20th, they applied for an EUA. And so between November 20th and December 11th, what the FDA did, and this is something that is unique among regulatory agencies around the world, is that they took the actual raw data from the Pfizer clinical trials and did their own independent analysis of the data to make sure that the analyses were correct and that they could corroborate the analyses done by the manufacturer. And indeed, that is what happened, is that their analysis also demonstrated that there was 95% efficacy among vaccine recipients in preventing any symptomatic COVID-19 disease. So because of that data and because of the review of the safety profile for the vaccine, FDA approved the EUA for Pfizer vaccine last Friday, December 11th, with the initial distributions happening this week around the state and the country. What is coming up is the Moderna vaccine. Now, on November 16th, they issued information that in their calculations that it demonstrated 94% efficacy, so very similar to the Pfizer vaccine, and they applied for an EUA application on November 30th. Now, this time frame has been spent doing the same thing, in which FDA has been doing more detailed independent analyses of the raw data from their trials, and they they are set to review this data with their advisory committee this Thursday, December 17th, so just in a couple of days. They just released some information about their analyses yesterday to the public. It is anticipated that as early as this Friday, if they're on the same time frame, that FDA may issue the EUA for emergency use authorization for the Madonna vaccine, in which case all the states are potentially able to order and then receive that vaccine in the coming week or so by next week. It is important to note that both of these vaccines are 2 doses, and so Pfizer vaccine is 3 weeks apart, and the Moderna vaccine is about 4 weeks apart. Next slide. So I want to talk a little bit about the safety and efficacy, and I'll talk specifically about the Pfizer vaccine, but I'll also touch a little bit on the Moderna vaccine. So the Pfizer vaccine specifically is approved for use in individuals age 16 and older. While the trials right now are for groups there's not a recommendation yet for children and pregnant women because the trials did not include them, but they're currently underway. They're already recruiting children under 12 and will be in about a month or two beginning to recruit additional children that are younger, as well as pregnant women. Some important things to note for the Pfizer vaccine is that people who receive that vaccine should expect that in the 1 to 2 days after the vaccination that they should have some soreness at the site of injection, and many people did experience fatigue or tiredness, headache. A smaller number of people also had a low-grade fever and muscle aches in the 1 to 2 days after. And I would emphasize that these are expected and really is an indication that the vaccine is actually working and that the person's immune system is responding to the vaccination. I'll touch a little bit on the Moderna. What they applied for was actually for approval and use in individuals 18 and older. And in the information that's been released, it has shown some very similar side effects or effects in the 1 to 2 days after in terms of the soreness, the tiredness, and the headache immediately post-vaccination. Most of these symptoms will resolve, again, within 1 to 2 days, and so they have been reported by the trial participants as mostly mild, meaning they did not cause any changes in their normal daily functioning. Next slide, please. So, again, in the Phase 1A, these initial allocations are going to our frontline healthcare workers in hospitals around the state. And so what happens is that with the available allocation that the federal government indicates that Maryland has, we place orders and those will be sent directly to the hospitals from the manufacturer or through the federal government's distributor. And we've been working with our partners at the Maryland Hospital Association and continue to do so to be able to make sure that all hospitals get a sufficient allocation to provide a vaccination for their frontline healthcare workers. And that is a priority, and we continue to have very detailed discussions with MHA going forward. Next slide. Wanted to talk about a little bit more detail about our long-term care facility program. CDC established the federal pharmacy program, or federal pharmacy partnership, in which states were allowed to opt in, and if we did, which Maryland did, we then would sign up every nursing home in the state. And so we did that ahead of time. Now, nursing homes are able to opt out if they wish to do so, but we would encourage every nursing home not to do so, because what this allows is that the federal partnership is with CVS and Walgreens across the country. And so here in this state, what would happen is that we have withheld a certain portion of our initial allocation, as I mentioned, so that CDC has those, and so they are working with CVS and Walgreens to then distribute those doses to CVS and Walgreens here in the state of Maryland so that they can take those doses to the nursing homes. So they're currently signing up long-term care facilities and scheduling clinics at the nursing home site for the vaccination of both staff and residents. We activated that program about a week ago, and so we anticipate that some of the first clinics at the nursing homes could begin as early as next week or the following week across the state. Next slide. Another important group is our first responders. We appreciate the work that Dr. Delbridge at MIMS and all of the EMS responders around the state and others have provided for individuals in the community. And we will also begin setting aside doses from our initial allocations for local health departments to be able to provide vaccinations for first responders. And so these clinics for the fire, EMS, and law enforcement may begin within the next 2 weeks. You know, I think that as we move forward with these vaccination clinics at local health departments and in other more community sites, we have put out the call for volunteers to assist with us to manage and help with vaccination clinics, and also for vaccinators. And so we have asked for assistance from our schools of our health professional schools, from school health staff across the state and others. This is a call to help Marylanders, and so we hope that everyone will stand up and answer that call. Next slide, please. It is important for us, and we know how critical having information that we are tracking, as well as making sure that the public have an understanding of where these vaccinations as public resource is going is critical. So we will be launching a public dashboard specific for vaccinations in the coming weeks, and will track not only total vaccinations, but also provide a more specific vaccination demographic breakdown in terms of county, race, ethnicity, gender, and other demographic information, so we have a better understanding of where vaccines will go. The numbers and the graphics in this particular image are just mock-up ones. This is not actual data, but certainly once we make it live on our website, it will provide actual data drawn from our Immunet program, which is the underlying system that is keeping track of all the vaccinations that are happening here in the state. Next slide, please. The public outreach campaign is very critical. We know that community understanding and education is absolutely necessary to be able to make a vaccine effort successful. Right now, our focus is on the 1A population, which is focused primarily on healthcare workers, and so educating healthcare workers and providers about the vaccines that, you know, both Pfizer and Moderna and also the other ones that are coming down the pipeline are very, very important. But we do recognize the equally critical nature of conducting outreach and education of our public. And so to that end, we have been convening with key leaders and stakeholders across the state, including yourselves, including legislators at the local level, elected officials, county officials, municipal leaders, to engage and get feedback and answer questions. In addition, we have been meeting with leaders in the community, with groups, minority groups, community groups that represent individuals who are vulnerable, and that is all a part of this multifaceted effort that we are making. We recognize that having multilingual education about the safety, efficacy, and availability of vaccine is important, and particularly as we move into phases 2 and 3. We understand about leveraging trusted leaders and voices, and appreciate the governor and others and the Lieutenant Governor adding their voice to supporting this vaccination campaign, and even offering when it is their turn to be able to be vaccinated in public. Next slide, please. Last, I just wanted to touch on a couple of the questions that we've been getting, and I know that there are many others as well. There's been some reports, particularly the Pfizer vaccine, about anaphylaxis and whether people with a history of anaphylaxis or severe allergy should get the vaccine. And right now, the CDC is saying that only people who have a known anaphylactic type reaction to any of the components of the Pfizer vaccine would be should not get it, should not get the Pfizer vaccine. But there are, as Dr. Marcosi indicated in our press conference yesterday with the governor, there are very few components of the vaccine itself, and so it would be highly unlikely that those individuals would be allergic to components of the vaccine. However, for anyone who may have a history of anaphylaxis to anything, to another vaccine or to another, to food or pets or another thing, that they might just need to be observed for a little bit longer. So we know that, and we're providing that information to our clinicians around the state. Some of the other questions are more general, so including, how long will phase 1A last? And I would get back to some of my earlier points in that a lot of this is predicated on how many actual doses the state of Maryland will get. And that is determined by the federal government. They are allocating not just to Maryland, but they're really looking across the country in terms of how they will allocate available vaccine. And so, our commitment is that we are allocating doses as quickly as we have them available, but it's an allocation to the state. We provide the ordering and getting it out to providers, and then there's the distribution, and then it is left to the providers that we coordinate with to be able to actually administer the vaccine, and that's an important step as well. And then in terms of when our metrics might actually begin to reflect the impact of the vaccinations, it's a hard question to answer specifically. Our goal is to get to as high a vaccination level as we can. I believe that Dr. Fauci has had some comments that we need to reach 70 to 80% vaccination levels, but for every disease, there's a different level of vaccination needed if there is a vaccine to be able to reach that population immunity. And I think that it may still just be a little too early to tell exactly what that level is for COVID. We would urge, and this is important, we know that there's already misinformation and rumors out there about the Pfizer vaccine and the Moderna vaccine, and we urge the public to get their information from credible sources, and Facebook is not necessarily a credible source. Please go to the CDC, go to the Maryland Department of Health website to get the latest information. So thank you, Madam Speaker, Mr. President, and I will turn it back to you. Thank you.
Thank you very much for each of your presentation. We do have some questions from some of our members. Our first one is from the Vice Chair Appropriations, Delegate Michael Jackson.
Thank you, Madam Speaker, and thank you to the presenters. I just have a quick question. When you speak of public safety vaccinations, does that include the correctional officers and the parole and probation agents who are responsible to respond in the community to those under their supervision? Thank you.
So thank you for that question. We are looking at all of those as law enforcement, and will attempt as best we can to make those available when we have vaccines available.
Thank you.
And just a reminder for members, we have lots of questions. This is incredibly important information, and really appreciate the detailed information. But if we can just ask members to be very pointed, we have guests that do have a time limit as well. So I'm going to hand it over to Chair of our Budget and Taxation Committee, Senator Guy Gazzoni.
Thank you, Mr. President. Doctor, could you clarify for me in terms of in the 1B section? I know there some folks in the developmental disability community are concerned and not completely clear yet about whether they would fall in that, particularly those in group homes who seem to have higher rates and of course also seem to have higher rates of passing up to 3 times as much in the general public. Would they fall into the 1B category?
Thank you, Delegate Guzon. We understand what the impact has been on the developmental disabilities communities as well as many other vulnerable populations, and we're doing that detailed analysis now to understand the numbers as well as where they may be so that we can begin planning for that. So that is a very critical component of our planning right now, and so that's where the detailed understanding at our level as well as, again, as we get more information from the federal side in terms of allocations, that's where that will all be plugged in. So we understand that. Thank you.
I appreciate that. I just want to quickly ask again, does that mean somewhere within the 1B category, or you just don't know that yet?
So, I think that that's where the planning comes in, whether they'll be able to fit into 1B. We also are going to be aligning as much as we can with the CDC's Advisory Committee on Immunization Practices, and we anticipate that there may be additional guidance coming from them as well. And so those are some of the factors that we are pulling into our planning efforts.
I look forward to hearing more about that. Thank you.
Thank you.
Majority Leader Lukey.
Thank you, Madam Speaker. Thank you for the presentation. I know you hesitate to offer any suggestions about what the timeline will look like of, moving to stages 1B and then 2 and then 3. But do you have a sense of when we will know that timeline of when we'll have a better sense?
So I would say, Delegate, that if we could predict with precision what the timeline would be, it would help us as well. And so we do hesitate to provide any specific dates because there are still factors that will drive our timeline that are a bit out of our control, including mostly at the federal level in terms of vaccine production and allocation. And so I think that it is premature to put out a timeline, but we understand that question, and we would like to have a more specific timeline as well, and that's what we're driving towards. We continue to get information from our federal partners, and that will help us with our planning as we move forward and as we work with our healthcare and other providers.
So it's unclear even when we will know what the timeline looks like.
At this time, yes. Again, as I mentioned, right now there are projections that we will get as many as 300,000 doses by the end of this year, but that is not even carved in stone, if you will. And so until the doses are actually in the system for us to be able to order off of, that's when we have certainty. And right now that is from week to week.
Thank you.
And so we don't have even projections beyond the end of this year.
Next up, we have Chair of our Education, Health, Environmental Affairs Committee, Senator Pinsky.
Thank you, Mr. President. Dr. Chan, you just mentioned 300,000 vaccines. And I guess my question is, you mentioned the first 150,000 from the Pfizer and Moderna. I guess my question is, in terms of dose number 2, which happens 3 to 4 weeks later, are you assured that you will get that second dosage, or are you currently holding back enough for the second dosage? In other words, not only do we have dosage number 2, but we want to expand the number of people who actually receive their first vaccination over the next 4 to 8 weeks. So can you talk about how you're quantifying and ensuring that dosage 2 and the expanded dosage for dosage 1 will take place?
Thank you, Senator Pinsky, for that question. I know that is one that we continue to make sure that we're connected with our federal partners on. So the 155,000 doses are for first doses. So in actuality, what the Operation Warp Speed has told us is that they are withholding the other 155, so that Maryland, essentially has a little over 300,000 doses allocated to us, and they're providing only half of it now as a dose 1, and then in about 3 to 4 weeks, they will be making available the dose 2 for those same facilities that received it. And then as we continue to get additional first dose allocations, we'll push those out as well.
Okay. Chairwoman of Health and Government Operations, Delegate Shane Pendergrass.
Thank you, Madam Speaker. That's working well. Dr. Delbridge, you talked about the fact that we have such an improved percentage of people in ICU who are being treated for COVID. And I'm wondering if anyone has quantified whether that is because of the way we're treating the illness, or if it's because of a demographic difference, as in the patients are less from nursing homes and more from the age group of 30-year-olds. Do you have any information about that?
Thanks for the question, and sort of very high level. It seems to be more about the treatment of the patients in the hospital than it does a change in the demographics. Although I can appreciate that there might be a change in the demographics. When we've looked at that sort of cursory or summary, it seems the number of hospitalized patients, or the proportion of hospitalized patients in various demographics, seems to be quite similar to the springtime. What is certainly true is that there seem to be more people infected who never get to the hospital. And that seems to be the difference in the demographic distribution, more so than who's actually in the hospital and where they end up in that space. And our insight into that is also rather anecdotal from the critical care physicians that are managing patients in the hospital, who point out not so much that it's a different patient population, but they're able to keep people out of the intensive care unit based on the treatments they're providing.
And how are you treating people who are in home? I didn't exactly understand what you meant by monitoring them.
Well, so the protocol that we distributed throughout the state emphasizes to EMS clinicians that we want them just to, by monitoring, I mean check up on people. So if they go to somebody's home, the critical pieces of information that they collect have to do with comorbid conditions. Do they have high blood pressure, COPD, or something else that would put them at risk for a complication from COVID, their vital signs, and their pulse oximeter reading, which is really the telltale sign of whether somebody is going to get in trouble in the short term. When they make the determination that all those things are satisfactory and the patient is acceptable for staying at home, we've emphasized the importance that they check up on them sometime later. And they've been doing that a couple of different ways. They either revisit the patient in their home 8 to 12 hours later, or make a phone call and just make sure that nothing has changed. And that's to monitor them in their home. And what we know from that is less than 2% of the people who they encounter and follow that plan end up in a hospital emergency department within 24 hours and get admitted to the hospital, which is just as fine as patients who go to the emergency department. The track record is actually a little bit better.
Yeah, I would agree that that's really good. I would be concerned that 24 hours is not a very long time period for follow-up, that sometimes these things come on quickly, but they wait a week before they do. And I'm wondering how you're managing the longer term at home.
Well, part of the interaction with patients is to give them some information about signs to look out for and when to call back. Not unlike if you went to a hospital emergency department, when you leave, you get discharge instructions that tell you things to look out for and when you should seek care, either with your primary care physician or return to the emergency department. The EMS clinicians are doing the same kind of thing. So they follow up in the short term to make sure that their strategy or their tactic wasn't in error. And then they rely on the patient to monitor his or her own condition, and when it changes, to call back or seek alternative care.
Thank you. And Dr. Chan, thank you for giving us that update in such clear layperson language. I appreciated all that. And also the pressure that you must be under from the lack of predictability from the federal government and the process at this point, and also trying to get things to people in a predictable way, which needs to be done with second doses in particular. Thank you, Madam Speaker.
Next, we have our Senator Lamb.
Thank you, Mr. President. Thank you for the presentations. And, I think this is a great time of hope since we now have COVID vaccine. I'm actually sitting about 50 feet away from one of the 1A COVID vaccination sites, and the amount of work and planning and preparation involved in handling the logistics and the administration of this vaccine, as I'm sure all of you are aware, is really incredibly unprecedented. The planning piece, however, is really important because of the challenges with bringing the vaccine on. And I'd like to avoid another episode of Kabuki Theater like we saw with the South Korean test and pose a very simple question as to how many doses of COVID vaccine we are expecting to have by the end of the calendar year. Can you answer that question? Because I know other colleagues in other health systems also have lack of clarity when it comes to that question. They've heard, I think 2 weeks ago in a briefing, that there would be 300,000 doses by the end of the month. Now we're hearing a more limited initial distribution of 155,000 doses. Can you be very specific as to how many doses Maryland healthcare systems can be assured to receive by the end of the month?
Thank you, Senator Lamb, for that question. And so, as I alluded to earlier, we have a projection, and a projection isn't just an estimate from the federal government that we may receive as many as 300,000 doses, first doses, by the end of the year. However, what we know for certain is the 155,000 of the Moderna and Pfizer vaccines. And so there is so that's why I want to caution that, there is an allocation process that is happening at the federal level. And so once we are provided certain numbers and to be able to order off of, that is when we have more clarity on the number of doses. And I understand that, not just for the hospital systems, but also for us here at the state, it would be extremely helpful to have specific numbers that are, certain and locked in weeks ahead of time for planning purposes. And as I indicated earlier, we would like that as well. But we are operating right now, right at the beginning of a real monumental effort that all of us are standing up across the state. And there is still some level of uncertainty that we are managing, and so I want to make sure to set that expectation. As soon as we have information and specific numbers, trust that we will provide that to the hospitals. But I also don't want to, and to other providers, I think that we be hesitant to provide specific numbers that then the federal government does not actually, allow us to order off of.
So you can assure of 155,000 doses by the end of the calendar year. You feel comfortable with that?
Yes.
Okay. And when it comes to the second dose, and this is to dovetail along Senator Pinsky's question, I am concerned about the timely receipt of the second dose, because as you're probably aware too, there's a small window by which to administer the second dose. And as we administer the first dose, actually scheduling them for their second dose already. And we need to make sure that we have that second dose come in to be able to get them vaccinated in that very small window. Can you confidently and absolutely assure us that we will have those second doses when we need them within that time window for all the folks that we're vaccinating currently with their first dose?
Thank you again, Senator Lamb, for that question. We know what the time frame is, and there is a window of about 4 days around, 3 weeks later, that the second dose for the Pfizer vaccine is needed. And so our role in this is to make sure to communicate very closely with our federal partners on that process. They, as they've indicated, are withholding that second dose to be able to be distributed in a timely fashion to all of the facilities who received it. So,
but are you confident? Are you confident that we will receive that second dose when needed?
That is something that we are pressing on our federal partners to ensure.
Okay, that's about as much confidence as I have too. Thank you, Mr. President.
Health and Government Operations Vice Chair, Delegate Jocelyn Pena-Melnick.
Thank you, Madam Speaker, and good morning, everyone. Dr. Chan, thank you so much for your presentation. My question is the following. Is there a master data sharing plan that includes distribution and storing of the vaccine, vaccine completion with second dose? And then also, is there data opt-out mechanism for undocumented or those individuals unwilling to share the personal information?
Thank you, Delegate Pena-Melnick. So if I understand your question correctly, we will be tracking the information about vaccinations very closely in the Immunet system. That is where all of the vaccination data will be kept, so that regardless of where an individual was vaccinated, and if they go, for example, to a different provider for their second dose, that information will be there. And so we'll be looking at that very closely, and that data will be collated and updated and put out on that public-facing dashboard that we are will be planning to roll out in the weeks ahead. In terms of your question about undocumented individuals, I'm not sure. Let me make sure I understand your question first, if I could, Delegate. Could you repeat that question?
So basically, is there data opt-out mechanism for undocumented or those individuals that aren't willing to share their personal information? If they're not engaged in primary care, how is this going to work when you move on to the other phases and you're collecting information? That makes them nervous because sometimes, as the NBA does, you share with the federal government and that information is used against them.
So our intent is not to collect information about documentation. Really, I think for vaccination purposes, the important information that's needed is to make sure that we identify not only the individual at the time that they receive their first dose in whatever setting, but also to make sure the same person, when they come back for their second dose, receives the correct vaccine because of these two-dose regimens. They have to receive the same vaccine the second time. And so we need at least sufficient information to be able to ascertain that it is the same person and that they received the correct vaccine. So that's the really important pieces of information we need.
And if I may follow up, Madam Speaker, what information would be sufficient? What kind of ID?
So there are different ways that we have approached that within our testing settings, for example, and that's a different challenge to make sure that we provide, for example, test results back to the correct person, and that the correct test results are provided. And so some of that information is in Immunet, and it may be name and things like date of birth, and perhaps an address or something that would help us at least be able to ascertain it's the same person. This is for specific healthcare needs to make sure that the person receives the correct dose the second time.
Thank you. I just ask that you be sensitive, especially in the Black and Brown community. They have really been getting the brunt of this disease. And as you know, identification is difficult in those communities, and we don't want to place any burden. Thank you so much, Madam Speaker.
Welcome.
All right. Our last question for this panel is our Vice Chair of Budget and Taxation Committee, Senator Jim Roosevelt.
Thank you, Mr. President. Dr. Chan, thank you very much. Two, I hope, quick questions. Number one is, what is your estimate, or what estimates are you getting from the federal government on their estimates of the percentage of the population in phases 1 and phase 2 compared to phase 3?
Yeah. Thank you for that question. So again, we're in detailed planning on that. We will need to get back to you on that. We're looking at all of that information and get back to you on that response.
Okay, that would be fine. It's very important, obviously. I appreciate it. Second brief question is, as you know, President-elect Biden has announced that his goal is to have 100 million vaccinations done by the end of April. That's obviously 2 million vaccinations in Maryland. Have you been in touch with the President-elect's transition team and/or with the current administration to sort of nail down what that means in terms of phase up?
Yes, so we have provided some feedback for the transition team. They've reached out not only to Maryland, but other states as well for feedback about vaccinations and other aspects of our response effort. So yes, we have provided that information to them.
I guess my question is, have they given you any information, or has the current CDC or HHS given you information about whether they agree with that goal and whether that, does anybody have a plan to reach that goal that you've seen? That's my question.
Not in that specific terms, in terms of the, 2 million in Maryland. We have not received specific information on that.
Thank you.
Well, that does it for questions. I want to make sure to thank the three panelists. This has been an incredibly complex time, and Acting Secretary Schrader, Dr. Delbridge, and Dr. Chan, we appreciate you briefing us today, and this was a very detailed providing as much information as possible, so we are very thankful for that. Thank you for being here today.
Thank you, Mr. President, Madam Speaker. Thank you very much.
Next up, we have the hospital side of the equation. So on the boots on the ground of handling this dual complexity, complex reality. We have three members of the panel. First, we have Bob Atlas, the President and CEO of the Maryland Hospital Association. We have Dr. Redonda Miller, President of the Johns Hopkins Hospital, and Dr. Malik Joshi, the President and CEO of Meritus Health. With that, I will hand it over to Mr. Atlas.
Sorry, I assume I'm audible now. Thank you, Mr. President, Madam Speaker, for inviting us to speak with you today. It's been an interesting 10 months, and I want to start by saying that we really appreciate the partnership of the state, the health department, and as well as our friends at the Health Services Cost Review Commission. For all the partnership and support that we've gotten. I want to be brief. I want to give you an opportunity to hear primarily from Malik Joshi from Hagerstown and from Redonda Miller from Baltimore about what's going on the ground in their environments. But I'll give you a little bit of a setup here. If you could go to the next slide. So if you look at the far right of this picture, you see every county is dark. What that means is that the case rates are now intense throughout Maryland. Earlier in the pandemic, where you see only a few areas were particularly dark, mostly in the National Capital Region, but also like Wicomico and Kent counties. And then on the far left side of the page, you see the difference in progression of the disease. And so it has affected hospitals and communities differentially at different points in time, with some of those more remote and particularly in the Western region now feeling the brunt of it most intensely. So that had, and truth is the country had similar experiences. I remember speaking to my counterpart in Virginia who thought they dodged a bullet back in the spring, but not anymore. So move on to the next slide, please. So this is a picture you've seen, I'm sure, many times. We had our surge in the spring and a mini surge, I guess, in the midsummer, and now we're experiencing an even higher surge than the spring surge. As you've heard, today's number is 1,761 or 62 in hospitals. I'll note that back on March 24th, we were ordered in Maryland hospitals to halt non-urgent and elective procedures. Just to be clear, elective procedures are not optional for people. They are procedures that simply can be scheduled. And hospitals abided that. And as I'll show you in a couple minutes, that had some impacts on occupancy as well as on care for other than COVID patients. That order was lifted right after the spring peak on May 5th. And We thought we were in recovery, but as everybody who knew what might happen when the cold weather hit and when people perhaps let their guards down, colleges reopened to students on campus and the like, we're now having that experience of this considerable surge. Appears that the slides have, is that just me?
Mm-mm.
Let's see.
It'll be fixed in just a moment.
All right. Well, we have all had our technical difficulties during these times. Okay. So moving on to the, I'll just note, as Dr. Delbridge said, let's go back just one sec, sorry. As Dr. Delbridge said, Governor on November 17th asked hospitals to submit surge plans. All hospitals have submitted those surge plans, working very closely with the state to make sure that we're ready for what may yet come in additional cases. We're certainly hopeful that we're seeing a peak again now, but cannot count on that. And vaccines will not stop what's happening now in terms of more hospitalizations. They will be very helpful, but not in the next month or two. Okay, now go ahead. Just comparing Maryland to the rest of the country, we look at this every few days. So this is the hospitalization rate for every state, the red being the US average. Maryland has consistently been to the left of this kind of chart. I will say we got down to about the 10th lowest at one point, but we're moving back up. We're doing, I think this is a reflection of the good efforts that we have had. I will note, some people who've seen this have at first blush have said, is there a difference between red and blue states here? I would say not much. So the point is that the virus travels, and we all have to take good protective measures to prevent the spread even more. Keep going, please. So this is a picture from our friends at the Health Information Exchange, CRISP. This is a comparison of inpatient admissions on the top and emergency department visits on the bottom. The line that says 0%, that is the number, that's last year on that same point in time. So what you see there is in March, as people followed the stay-at-home order and then abided the governor's, and then hospitals abided the governor's directive to reduce non-urgent procedures, hospitals started to empty out. Utilization overall, including COVID, was 30% below for inpatient, and it reached 50% below for emergency visits. And as you can see, even after stay-at-home orders were lifted and embargo on non-urgent procedures was lifted, we have not yet really returned to past volumes, especially on the ED side. You know, some of that may be attributed to fewer cars on the road crashing into each other, but you know, we're really concerned that patients who need care for all conditions are staying away, and so all of our public messaging has been that hospitals are available, are safe, and we want to make sure that people don't hesitate to get the care they need, not just for COVID, but for heart attacks and strokes and exacerbations of serious chronic conditions, and you name it. Going on ahead, please. So this is, oh, back one. This is a picture of hospital occupancy. So green is COVID, blue is non-COVID, gray is staffed but unoccupied beds, and the white is physical beds that are not staffed. Obviously, the staffing can vary somewhat. So you see in the spring, we ramped up capacity, created more physical beds. You know, you saw the green shows the surge that I was showing earlier, and you notice that you the non-COVID care dropped considerably from what it might have been. Back in the summer, we returned to what might be considered to be a normal-ish level of non-COVID care. And then now that we're having that COVID surge, we're seeing some decline in the non-COVID care. What's important to note here, though, is that gray area. We have never really fallen below about 1,000 available staffed beds across the state. There are certainly individual hospitals that have seen strain. We really appreciate the state's effort to watch that. Dr. Delbridge talked about this Critical Care Coordination Center to allow for hospitals that are filling up to transfer patients, to seek help in transferring patients to hospitals that have room, and so forth. So we are not reaching that 8,000 level that would suggest a need to add staff. It's really, truth is, it's not all about beds. It's really about people, as you'll hear from the hospital leaders who will speak in a moment. We have plenty of beds. It definitely took some effort to create this extra space. A lot of building and retrofitting space for things like HEPA filtration and the like occurred. It was not easy, but we're not worried about number of beds. We're worried about staff to take care of the patients. They've been at it for now months, and the strain is certainly showing. And one more slide, please. And so to turn to some of the good news here, this is, you saw actually one of the same picture on the right earlier. Initial vaccinations did take place the other day at University of Maryland Medical Center, which did receive what was called a pre-positioning shipment of some doses of the Pfizer vaccine, which was done to test the logistical functionality of the process. So that's why that facility was able to do that. You heard a very thorough presentation from Dr. Chan about what's coming. We are in constant contact with the health department, and they are kind enough to do multiple calls per week with our members so that we can be as informed and coordinated as possible. With that, I'd like to turn now to Dr. Malik Joshi, President and CEO of Meritus Health, an independent community hospital in Hagerstown, where things are kind of busy right now.
Thank you very much, Bob. Next slide, please. Thank you very much for the opportunity. Mr. President, Madam Speaker, thank you to Maryland Department of Health. We really appreciate your incredible support and your really steadfast dedication to this effort. Thank you, Secretary Schrader and Dr. Chan and Dr. Delbridge. And I also want to just thank Bob Atlas and the Maryland Hospital Association team. They have been incredible facilitators, collaborators, and have been incredible in helping us to learn from each other as we get through this pandemic as a state. So thank you, Bob. So on the next slide, I want to just level set us in 30 seconds in where we are. So of course we serve Washington County, 150,000 people. One thing that makes us maybe different than others is we have a very strong unified command approach. Myself and the health officer for Washington County, Earl Stoner, are the co-incident commanders for the COVID-19 response for the county. So we are together all the time talking. We have one person in their incident command. They have one person in ours. We have daily calls. So again, a very coordinated approach to take care of our county. And of course, we also serve Southern Pennsylvania and West Virginia as well. From the beginning, we really focused on one of the most important public health practices of testing. And so we've focused heavily on frictionless testing. Since the start, we've had no appointment necessary, no charge to the patient, no doctor's order, no symptoms, and we have processed 80,000 COVID-19 tests since March. Almost 80% are processed by our own Meritus Medical Lab with a turnaround time within 24 hours. This drive-through testing, as you can see the picture, we just set up with a couple of trailers and a wedding tent. And we process nowadays 600, 700 tests a day and have done over 1,000 cars a day as well during some of our stress times. But again, it's our approach to continue to do our best in terms of identification and the follow-up, working with the county for contact tracing. Obviously, there's no treatment for COVID-19, but we have been fortunate to try all the science-based approaches in terms of pharmaceuticals and others. We're fortunate to start the Bamland Regional Infusion Center, which is the antibody, where we're one of 5 sites in the state, and I know growing. We've done over 60 infusions and we continue to increase that over the coming days for the newly diagnosed COVID-19 patients 1 to 10 days who have one of the risk factors. This 1-hour infusion followed by 1 hour of observation is starting to grow. Of course, the most important thing is our healthcare heroes. Bob said it and others said it. We have beds, it's staff, and it's a challenge. We are all fatigued. We've been at this for 9 months. Back in the spring, we did not do furloughs or layoffs. We put in a pay protection program. So we redeployed staff at that stage in terms of any types of roles that we could think of. Today, we are still redeploying many staff, but many people are taking on extra shifts. We're providing incentives. We have a helping hands program. So if you're a non-clinical person, you can go and help on a unit and help a nursing assistant. I've done 2 shifts myself of 4 hours each, and you help the nursing assistant with the trays, with giving out waters, with whatever they need to make it so that they can take care of patients and you can take care of the other stuff. So that's in place as well. We are hiring agencies, nursing staff. We just had 12 come on Monday, and we continue to pay ridiculous amounts of money to make that happen as well. But we're here to take care of the community. On the surge itself, we were fortunate back in March that we did apply and get the certificate of need approval for a 20-bed infection containment wing. We got the approval in March, broke ground 8 days later, had a ribbon cutting in August, put patients in by the end of August, and by October, we filled our 20 beds, unfortunately. So we have 20 there all the time. Negative pressure wing, ICU capable, ventilator capable. Again, it's one way to try to get us towards having the capacity permanent. As we know, these types of unfortunate emerging or infectious diseases are out there. One very small silver lining to this is this wing is actually on the ground floor. So we have windows outside to all this. And over the last couple of months, we have their families and loved ones outside the windows being able to see and talk to their loved ones with COVID-19. A very small silver lining, but it is, as you know, with all that we're doing for safety in terms of visitor restriction, this has been an effort. We've put out benches there. People have put bird feeders outside the windows. As you can see, cards here. This is a daughter whose mom was there, who's fortunately home doing well now. Actually was an OR tech for us for over 40 years. And again, little things like this can make a difference. We are at almost 100 COVID-19 patients. Obviously, it depends on the hour and the shift, but over 25 in the ICU. And the positivity rate across our county from all the testing we're doing is over 15%. Obviously, a little bit different than what the county reports because there's others doing it, although we do about 95% of the testing in the county. Next slide, please. We are preparing for the vaccine, and thank you to Dr. Chan for outlining that so well. We are expecting to receive 1 box in the next 2 weeks. Our team is ready to go to administer as soon as they are here. No surprise, we have about 3,000 employees and another 500 medical staff. So that's 3,500 people for the 1 box of 975 vaccines that we're get to start. And so we've prioritized to, according to CDC and other guidelines, those in the emergency room, the ICU, our COVID units, clinical and non-clinical, environmental services, security, transportation, registration, everybody who's in closest in terms of risk of exposure. Obviously, also, we're working with the county, so we will deploy to further and work with the county to prioritize and do that efficiently, as we have been doing in many ways. Next slide, please. I think if you step back and we think about how we've been able to take care of our community, being agile, all of our health systems in the state have done that. I know Dr. Mill will talk about the amazing work they're doing. But drive-through testing, we never would have thought a year ago that we would have, again, a couple of trailers and a wedding tent, literally seeing hundreds of cars every day, giving flu shots, doing COVID-19 testing, anything possible to get this addressed quickly. Community orientation from the get-go, we provided a free COVID-19 hotline. We provided free video visits. In case you have no physician, we're happy to do that for you. And again, we've provided no patient charge for any COVID-19 testing. That's added us to about $600,000 since March that we have not charged patients. We bill the insurers, but we don't charge the patients. It's the right thing to do for us. Of course, taking care of our staff and providers is the most important. Can't say enough about our healthcare heroes. As I said yesterday in a press conference in our county, they perform miracles every day, but they can't perform magic. So we need everybody's support to keep this virus as best in bay while the vaccine is being deployed. But we try all the things. We have provided them recognition. We do surprise visits to people who've been nominated and they get a COVID-19 hero pin. I wave some pom-poms. They get a bag of healthy snacks. We're trying all the little things that make someone's day a little bit better. We have compassion fatigue rooms, or Oasis rooms, we call them. One in every floor of the hospital. It's a 10 by 10 room, has a great massage chair in there, has some very dim lighting, and it's a chance for any staff person to go in for 10 minutes and take a break, a micro break, to help recharge themselves for the rest of the day. That's just, again, one way to try to support our staff. Obviously, early on, PPE was a major concern. We're in a much better place today, although we work on it every single day, somebody trying to get additional PPE, but we're in a much better place, and thank you to everybody for making that happen. But we're continuously trying to communicate the fundamentals of what's going on, all the changes that are going on. We've also done a lot of mindfulness activities. Again, taking a couple of minutes out of your day in the beginning of a meeting and just focusing on something other than work to put your mind at ease and get going. The last thing, obviously, no surprise, is partnership with all. We have been fortunate, but in this county, we work with everybody, our Chamber of Commerce, our Greater Hagerstown Committee, everybody, to really focus in and be educated and communicate. The last slide on the how can you help, we would, again, very much appreciate the continued emphasis on wearing a mask, washing your hands, and socially distance. If you could go to the next slide, please. The 3 W's are continuing to be critical, and we can't say that enough. Always means always when you do these practices. Obviously, it's a holiday season. Being safe during the season is so critical. Educating all of us on the vaccine. You've heard about it, but its benefits and how we get there. And then, of course, in the world of not only playing hockey now, but skating to where the puck will be, 2 things in the future. Mental health, that is going to be, as you know well, such a critical piece. Today, it's a critical piece, but COVID-19 is again highlighting some of the challenges that we all face as human beings, especially as you think about social isolation, loneliness, and all the reasons of our isolation. So this is something not to fund hospitals, but to think about how do we have enough resources in our health system as a state, as a country, to address some of these issues, not just today, but even a growing set. I think you've all seen the stuff that loneliness or social isolation, that impact on health is like smoking 15 cigarettes a day. And this is real. And then, of course, the other one, you all have been talking about it, you have a task force, but seeking meaningful change in disparities reduction. COVID-19 has shined the light on this, but it's no different than asthma or diabetes or a number of other conditions where race, ethnicity, gender, other demographic variables have an impact on your outcomes. So really focusing on the systemic inequities and the diversity in leadership and other things that get us there. And finally, of course, as I mentioned briefly, PPE, lab supplies, all that stuff, we're in a better place, but we need continued focus on that and how we support our amazing healthcare heroes. I'll turn it over to Dr. Redonda Miller.
Hi, everyone. If I could have the next slide. I'll just also echo what Malik said as far as thank you for this opportunity to speak. Thank you, Mr. President, Madam Speaker. It's a real pleasure to be here. If you could go to the next slide. Before I launch into a little bit about partnerships, I wanted to echo what you just heard that is touching all of our hospitals, and that has to do with the issue of staffing. Certainly we struggle with quantity of staffing, that is for sure. Here at the Johns Hopkins Hospital, we also have about 100 plus COVID patients. Many of ours are ICU level of care, around 40 or so today, so a little higher percentage, and that's by design. We've taken a lot of our critical care patients from the rest of the system and through the triage process. But trying to find critical care staff, nurses, respiratory therapists has become a real challenge. We've had to use a lot of agency, 150 agency nurses now to almost 250, and the price tag, as you heard, has gone up. It used to be around $80, $90 an hour. We just recently paid $200 an hour. So this has become increasingly difficult. And on top of that, we're seeing staff infections. In the month of October, we had about 140 staff out with COVID and now around 400. And this is to be expected from just the increased prevalence of community spread. But on top of the shortages, which are critical, the morale, the pandemic fatigue. I won't belabor what you heard Malik say, but it is real, it is true. We're trying to wrap so much support around our staff, morale boosters, financial assistance programs, mental health assistance programs, well-being. If you can imagine, if you're on the front lines, you're worried about going home every day, infecting family. On top of it, you may have 2 or 3 kids at home that are trying to juggle virtual school. And then you may have elderly parents who are isolated and you're trying to help. It is tough. And that's all I'll say now. And I'll move on a little bit to what else I want to tell you about today. And that is hospitals are not going it alone. We have very much formed partnerships, health systems with other health systems with other organizations to maximize our resources to provide care to our local communities. Here in Baltimore City, we knew we would be at risk for high prevalence of COVID. We have a high underserved community, minority population. We have a lot of essential workers. We just knew some poverty, that Baltimore City would be at high risk. The first partnership I'll tell you about is called the P3 Partnership, Public-Private Partnership. It was work of JHM, University of Maryland Medical System, and Care First. And we thought we could pool our resources to really make a broader impact. What we did, and I won't belabor this org chart below, but you can see that at the bottom, there are 7 work streams that have launched. And this launched very quickly back in March, right away. So work that's been done include the call center on the left there, communications work, dashboards, hotspot data tracking, work with testing and transportation, special populations, and care coordination. If I could have the next slide. 2 of those work streams to highlight is the work around communications. And this was several different approaches. One was making sure Baltimore City had the expertise they need, the expertise in how to prevent COVID, and also working on different communication channels. Not everything is an email. We needed flyers. We needed different types and strategies around communication. We needed culturally sensitive communication. We needed communication in different languages like Spanish. So that that was a real nice collaboration. And then on the bottom there, you see a couple of the dashboards. We helped with some of the technology behind this, helping Baltimore City launch dashboards that would allow them to not only report statistics, but also then do the tracking and the tracing and really identify the hotspots so resources could be targeted in those areas. Next slide. Very proud of the work at the Convention Center. The Baltimore Convention Center Field Hospital, partnership with Johns Hopkins Medicine and University of Maryland Medical System. This was initially designed as a place for patients to go who either didn't quite need acute care or needed acute care and were now convalescing from COVID-19. So patients who were not critically ill, needed maybe up to 4 liters of oxygen and could go there. This is a well-run machine. They have a code team, they have physical therapy, all kinds of staff. It really is well designed. Got off to a little bit of a slow start, but now we are maximizing the use of this. It's running a census now of around 25 to 35 patients, drawing from over half the hospitals in Maryland, average length of stay of about 5 days. But we've been able to broaden the purpose of this field hospital. In addition to taking care of patients, it is a testing site, and they've done, over 55,000 tests today. Many of my friends have used it. It's easy. You can make an appointment. If you don't have an appointment, there's another line for non-appointments. You show up, you get your result within 24 to 48 hours. Really good reviews from patients. And then finally, more recently, it's tailored itself into an infusion site for bamlanivimab and some of our other monoclonal antibody therapies. Just as you heard Malik say, these therapies are delivered here over, 106 infusions as of yesterday. Next slide. The Lord Baltimore Hotel was another partnership between the 3 entities you see, us, Maryland, and Baltimore City. We found that we had patients who, even though they may not need an acute hospital stay, or they did and they were ready to go home, they didn't have the means to self-isolate. We have many patients who are living in multi-generational households, very crowded conditions. Now we could use the Lord Baltimore Hotel that would allow them to convalesce safely. They don't need medical care, but this is a place where they could go, have meals, get the support services they need, and most importantly, protect their other family members and friends. Current use, we have about 83 residents there who are isolating and convalescing. Go ahead to the next slide. And I will say, before I leave that, a lot of these patients, in addition, were patients experiencing homelessness. You can imagine trying to convalesce if you don't have a place to go. So that has been a real boon to the community. Here on this slide, I want to mention our work in testing in the community. We were, through the Baltimore City and some of our hotspotting, it was brought to our attention that the Latinx community just south of the Johns Hopkins Hospital were seeing a lot of patients who had probable COVID and did not have access to testing. These patients were at incredibly high risk. As I mentioned, they may live in multi-generational households, so very crowded. Many were essential workers. Many may be worried about accessing the healthcare, either language barriers or perhaps they were undocumented, but it was clear that testing needed to be brought to them. So we marshaled our forces. You can see in the graph below, we've done over 3,000 tests in this community to date. And this was at the Sacred Heart of Jesus Church, on the bottom right of that table, 32% positivity. 32% positivity. What's more important is after the test came back, we made sure that they had access to care. If they needed hospitalization, we brought them right into Bayview or here. If not, we made sure they had appropriate outpatient follow-up, provided education, and then also connected them with additional resources. Maybe it was access to Amazon food boxes, or they needed to go to the Lord Baltimore Hotel. We plan to continue this throughout the winter months. We brought in some modular heating units, and we will keep going. Next slide. And this is my last slide. I want to just mention, this isn't so much about priorities, but a little bit about vaccines. You heard earlier about all the incredible logistics needed to provide this vaccine to patients. And I just want to personally thank our supply chain, our pharmacy, our occupational health team, Senator Lamb here, that's your team. So the logistics behind getting this to our patients have been immense. We vaccinated our first patient today. This is a game changer. But internally, I will tell you, we worry about disparities. We know here within our own 11,000 employees at the hospital and 40,000 across the system that we have a lot of staff who are underrepresented populations, Black, Latinx. They may not have the right access to email. They may not have computers. We are bound and determined that if they want the vaccine, they will get it. And believe me, this is an important group. It's not just doctors and nurses on the front line who need the vaccine. It's staff who deliver meals. It's staff who clean the rooms. These are essential staff that will keep the hospital going. So through our Office of Diversity and Inclusion, we've done a lot of outreach and education personally, messaging at all literacy levels, putting some of our messaging in Spanish, a lot of different vehicles, paper, text, face-to-face, groups, face-to-face groups to tell people about the vaccine. Computers, making sure everyone has access to computers. And then so many of our colleagues have signed up to be champions and ambassadors who will go one-on-one and help people access the vaccine and sign up if they want it. And of course, we're going to monitor our success. It's important that we make sure we're living up to what we intend to do. So maybe I will just stop there. Once again, thank you all for allowing us a few minutes of your time today.
Okay, we do have some questions thank you very much. We do have some questions from our member, Minority Leader Nip Kipke.
Thank you, Madam Speaker. It's good to see you all. Dr. Joshi, I wanted to let you know that Hagerstown resident was in your place for a few days recently and fortunately is home as of last night, but she wanted me to thank you and the staff for the tremendous work that you did to take care of her. And, you know, she went on and on about how wonderful the nurses were and how professional and caring and empathetic. And so good job to you and to your staff. You mentioned when you spoke that there were some challenges with PPE and, you know, obviously there's more demand for that. I'm just curious, is there anything that the state, the health department can do to be supportive or assist you, or do you have it under control? Thank you. Thank you, Madam Speaker.
Thank you for that question. So today we're in a much better place in PPE, I would say, and thanks to everybody at the state that have done that support. Early on, obviously, we had some challenges. The message, though, is I think we continue to focus on it. So I wouldn't say we are comfortable with where we are. We are always looking for the basics in terms of gloves and gowns and other things, but we're in a much, much better place. Safety for our staff is so critical. But we can't lose sight of, in this country, it seems to be a challenge to get some of the fundamental things like plastic pipettes and things like that for our lab. And we have to figure out how we can be better producing this for our own industry. So that's something I think for us to think about, not just as a state, but as a country.
Next up, we have our President Pro Tem, Senator Melanie Griffith.
Thank you, Mr. President, Madam Speaker, and to both panels. Thank you so much for your presentations. I was listening with interest and really appreciate the compassion and really the caring that came through when you talk about caring for the community and also about taking care of the staff. We've been hearing reports nationally about shortages in terms of healthcare providers, and I kind of wanted to hear how helpful a tool telehealth is as you look at these shortages. Particularly, I think it was Dr. Miller that talked about even provider infections and healthcare worker infections. So is telehealth providing some support for those kind of needs?
Absolutely it is. And when I think of telehealth, I think of two different modalities. So certainly in our inpatient wards, We have deployed cameras in the rooms with patient permission, of course. If we can't find a sitter, that allows us remote monitoring of that patient if they're at a fall risk or they have some delirium, that will allow us constant 24/7 one-on-one eyes. It's also allowed our intensivists to be spread so they can be through a technology we deployed in the pandemic called Sick Bay, so that we can remotely monitor all of our critical care patients and immediately have the expertise to send someone in the room. So it's been very helpful inpatient. And then outpatient, telemedicine has been revolutionary. We went from doing about, I would say 9 visits a week through telehealth in February to over 90,000 in April across our system. What was a 3 to 5 year strategy became a 3 to 5 week strategy. And patients, for the most part, love it. Even some of my patients who I never thought would embrace it are eager. They don't have to drive. They can have care delivered in the comfort of their own home. Even, I will tell you a new use we discovered today as we anticipate the winter storm coming. Now, instead of if we have to cancel closed clinics tomorrow, we can just convert them to telehealth. One thing that would be incredibly helpful, if I could just ask, we do have patients who don't always have laptops or computers or iPads. And so the visual component of telehealth it's very important, but so is just the actual voice part. So continuing to allow us to do telephonic visits is just very helpful for some of our population of patients who are disadvantaged and maybe don't have that technology. But thank you for asking.
Sure, and thank you. And I hope that all of you can kind of help collect data as we go through this. I mean, the 9 to 90,000 is just an amazing number, but I hope we can start collecting data about morale and other impact factors. So thank you so much. Thank you, Mr. President, Madam Speaker.
HGO Vice Chair, Delegate Jocelyn Pena-Melnick.
Thank you, Madam Speaker. And thank you so much, Dr. Miller. We know that there were requirements early on to shut down certain services. Can you speak to what your hospital is doing now to keep those services available? And also, how have you, what have you considered regarding the visitations policies? Did you have to make some changes as well?
So thank you so much for those questions. So the first question has to do with what we had to do. You know, in the first surge back in the spring, it was crucial. We didn't have the right staff or bed capacity. It was an unknown. So stopping procedures, elective procedures, was the right way to go. But we did learn some lessons. You know, we learned that delaying care for patients who had other conditions had ramifications. So we are doing our best right now to try to maintain care for both our COVID patients and our non-COVID patients. I will tell you, because of staffing concerns and staffage shortages, you know, just layering on 100 extra COVID patients and the staffing needs, we have had to ramp down our surgeries again, focusing on only delaying the elective cases right now, but we've had to cut down. As of last week, it was around 15%. This week, we're looking at around 30% because our ICUs here are filling up. We have about 45 ICU patients. So we're doing our best. We have a lot of predictive capability that we're tweaking our census day by day, trying to get every patient in that we possibly can for ICU care. But it's a challenge. It's a big challenge. The second thing I think you asked me about was the visitor policy. This has been, I would venture to say, one of the most difficult things about the pandemic. It has been so difficult for our patients and their families not being able to connect one-on-one. And it has been incredibly difficult for our staff. It is the right thing to do when you have the prevalence that we have in the community, trying to limit spread inside and outside of the hospital. But even our staff are saying, oh my gosh, they try their best to connect patients with tablets. We have tablets we deploy at the bedside and try to help patients connect. But you know, it's not the same as being in person. It takes extra manpower. So it's a challenge. What's different about this time is we do know we have some populations we're able to allow visitors, right? Kids, laboring moms, patients who come in for trauma, and patients who have disabilities. And of course, I forgot to mention patients who are dying. But those are the populations where we really understand those are special situations and have accommodations made to allow visitors for them. So thank you.
If I could just add on the visitor, same lure, we have people who are going unit by unit and just sitting and being companions to patients. And that makes a huge difference. So that's one of the advantages, redeploying team members to other areas and helping to make those Zoom visits. And it's not just for the patient, it does make a difference to the staff as well to know that that connection is happening.
All right, I think we have our final question for the day from Senator Lamb.
Great. Thank you, Mr. President. Thank you all for the information and wonderful presentations. I had a question, and this dovetails on some of the first information that we heard as part of this briefing, which is the state's effort to try to increase bed capacity. And I'm concerned because that's only one piece of it, as Dr. Miller has mentioned. But also, given our current trajectory, it seems like the number of cases, hospitalizations, and ICU cases has gone up and continues to go up, as well as the positivity, which has now exceeded some of the prior guidelines for when restrictions and shutdowns and limitations should be put into place. My concern is that it doesn't seem like the governor is taking on efforts to slow down the number of cases that we're seeing with further restrictions and limitations. And I think this is important because what's lost in the sight of all of this is that the reason these restrictions are put into place is to really safeguard our healthcare system, to ensure that there is sufficient capacity for people who need beds to be able to come in, but also for there to be sufficient staff to be able to staff these beds. And so I guess my questions then are to Dr. Miller and Dr. Joshi, and maybe Mr. Alex can speak to this from a broader perspective. Given the current trajectory, how likely is it, do you think, that we will breach the capacity of our healthcare system, given the tables and the graphs that you've shown, and not just beds, but staffing, which we know and I know is incredibly challenging right now. And these are staff that have been working incredibly hard for the last 10 months, running on overdrive and now running on fumes. Given the current situation, do you think it's more likely than not that we'll exceed the current capacity that we saw in some of those earlier charts?
Maybe I'll start on that, and I'll ask my colleagues to follow. But you know, the forecasting here is very difficult. We do think that the case counts will go up. I mean, right now we're at right about the 3.5 week mark from Thanksgiving, which is about the time that people who might have picked up cases then would be appearing at our hospital doorsteps. And you know, right now it looks like we're going up, but you know, 2 days ago we went up, and yesterday we went down by 3 dozen. So it's
but the general trend's been increasing fairly significantly.
It's hard to say what's going to happen. We are preparing for a much higher caseload. As I noted earlier, you know, we still have over 1,000 staffed beds available, unoccupied across the state. As Dr. Miller said, they are starting to ramp down procedures. We certainly do want everybody in the community to do their part. This is not a joke. This is serious. People need to wear their masks, maintain real social distance, and practice good hygiene. And we're steadfast in our insistence that that people do abide those guidelines.
If I could chime in too, I agree that these models, I follow quite a few of them, and they're different in what they predict, as you could imagine. And it's not anyone's fault. The variables that you need to input, as you know, are complex to put a number around. What's different, I think, about this surge that I'm going to try to remain a bit hopeful about is this vaccine is a game changer. If we can get our most vulnerable residents of Maryland vaccinated, I think that is going to help. And the new therapies, you know, patients now can, when they are admitted, the remdesivir, the dexamethasone, we've learned how to better care for them, better use of high flow oxygen as opposed to going straight to intubation. Once you're intubated, you're here for weeks. So with those two factors that are different, hopefully we won't hit some of those predictions of bed needs across Maryland. But I do share your concern, and I don't think we know how this is going to play out yet for this particular surge. I think there are too many unknowns.
Yeah, thank you, Senator Lamb. Just very quickly, I go back to the quote, all models are wrong, some are useful. So I think, we've got models, we've got the best science and evidence behind it, and we're working towards that, but it does show a different trend. The other part is, this is a beauty of being in healthcare. We figure it out. I mean, Redonda's organization, ours, amazing people who will work an extra shift, stay at night, snows here. I see 2 inches outside already now. We've got 80 people sleeping over tonight. I mean, we figure it out in healthcare. We will do whatever it takes to take care of our community. We can surge another 80 beds. It won't be the best ratios and not the optimal way we want to do it, but we'll do it. So I think, have confidence in our system, but it is a challenge, and we just have unknowns in terms of what the real numbers will be.
Dr. Miller, Dr. Joshi, I know you're working incredibly hard for our communities. Thank you again, and thank you, Mr. Atlas, too. Thank you, Mr. President.
Right. And I want to thank this panel and the panel before you for your valuable information that you had shared with us. I also want to thank the essential and frontline workers at the Department of Health in our county governments and all of our healthcare providers across the state for their hard work and sacrifice. I want to encourage everyone on this call to model the safe behavior that we need for every Marylander. We will continue to educate the public about the vaccine and remind them to wear a mask, encourage them to minimize unnecessary travel and get tested when appropriate. Please continue to look out for your constituents, particularly those who are most vulnerable during the holidays. We'll be in touch when we schedule the next work group meeting. So we advise you just to check the hearing schedule on the General Assembly website. Stay safe. And with that, I will turn it over to the president for some thoughtful comments that he'd like to share. So.
Thank you, Madam Speaker, and thank you to the representatives from the Hospital Association and the hospitals. We are deeply, deeply appreciative, and the P3 has really been a remarkably positive experience, and the innovation that's happened to try and deal with this crisis has been excellent. So thank you very, very much. I want to thank all members of the work group, and this is a bit of an unplanned addition in closing remarks, but it has all happened as we've been sitting here today. A good friend of mine who is in his young 30s, lives in the district, I had heard was tested positive for COVID and had checked in earlier this morning. And as we've been sitting here, he sent a message, and I think it's important to read his thoughts because it just, to me, hit me as how real this crisis is. So he says that he's on day 7 of symptoms, was in the ER on Monday, felt better yesterday, but today breathing gets worse. Oxygen holds at 94, but if it drops below 92, I'll go to the ER again. My wife so far is asymptomatic, but today she's starting to feel fatigued. This is such a horrible experience that I wouldn't wish on anyone. I've never felt so terrible before, so uncertain of the future, and so scared I may not have one. It really puts life into perspective and makes you deeply appreciate everything. As he thought through how he came down with the virus, he said he's pretty sure that he got this because his best friend's dad died. And when they went to console him after leaving, he developed symptoms 5 days later. He tested positive, and everyone else in the group also tested positive. His advice was, I implore you to please share this. Trust no one, never drop your guard. Insist that everyone be tested and quarantined prior to any meetup. If you don't, they could be asymptomatic, and this too can happen. Please be very, very careful to let anybody new into your bubble, even for a moment. This is the experience. This was the message that came in as we've been sitting here today. And so we likely will not meet before the holidays, but I felt that it was important to share this very real experience that a friend is facing because now more than ever, our vigilance has to be high so that we can get to the point of widespread vaccine distribution. So we're going to get there, but these next 4 months are essential. So thank you all. Stay safe. Enjoy the holidays safely, and look forward to seeing you all.